Hi everyone, thanks for coming. I'm Vipul Shah, one of the ICU doctors. I'm going to be talking about DKA. And so this is pretty informal, so the idea that I had for this was that I just present the topic, give you guys a case, and then really it's about giving you a chance to ask questions that you may have about the management of DKA, pathophysiology, whatever that comes up, okay? So if you have any questions about it, just kind of interrupt or say hey, or raise your hand, whatever. So I always like to start with a case, and so this is probably a pretty familiar case to anyone who works in the NICU. Sorry, 1 second. So 22-year-old male, history of type 1 diabetes, who's normally on Lantus and coverage for during meals. 1 day of severe nausea and vomiting, severe abdominal pain. He ran out of insulin about 2 days ago. And so typical vital signs for somebody who we would see like this comes to the ED. Pretty high respiratory rate, heart rate of 125, mildly low BP of 90/50, and usually a normal temp. You know, oftentimes DKA can be triggered by infection, things like that. So you might see somebody who has a fever, but you know, this guy just forgot to take his insulin. And these are the lab values that are often associated with DKA. You'll see kind of a low sodium, potassium is 4.2, chloride's 90. The big thing about it is bicarb's 13. And then things like positive beta hydroxybutyrate, and then a glucose of 420. Things that are really important for us is the anion gap. So how do you calculate an anion gap? Anyone know? Say louder.
Is it bicarb and chloride? Bicarb minus chloride?
No. So the thing about an anion gap is what your difference is between your positive, your cations minus your anions, okay? So there's generally a gap of about 10 to 12 in a totally healthy normal person. Can be different in patients who have liver disease where your albumin's lower because your albumin contributes to your anion gap. But the main thing is the difference between your sodium minus your chloride plus your bicarb, right? So you add those two together. So these are negative. These are your anions, that's a cation. Your potassium is also a cation. So you say, for this person, 126 minus about 103, right? So their anion gap is going to be considered to be 23, which is an elevated anion gap. So like I said, there's typical things the things that typically cause metabolic acidosis within an anion gap. Have you guys ever heard the mnemonic mud piles? Alright, so that's the typical thing there's a couple things that are typically involved with an anion gap, metabolic acidosis, and diabetic ketoacidosis is one of them. Right, so the D in mud piles is for diabetes. The other things are things like methanol. So when we talk about people who've taken antifreeze or things like that, that's ethylene glycol, uremia, lactic acid. Right, we see lactic acid when we see an elevated anion gap with that. So those are things that cause elevated anion gaps. But in this patient, the anion gap is about 23, and so the typical thing for this would be keto acids. So what does the patient have? Obviously DKA. And so when have you guys seen DKA? What types of patients? What kind of diabetic patients typically get DKA? And why is that? Anyone know really?
Because their pancreas produces no insulin at all.
Yeah, it's complete absence of insulin, and so they're more prone to it. Patients who have type 2 diabetes often have some insulin production, they just have an insulin resistance syndrome. So they will have enough insulin to make sure that they don't develop this cycle, but they can get other kind of complications of diabetes, some things like hyperosmolar comas, but they typically are much slower and have much higher glucose levels. This is typically in patients who just have a relative or absolute insulin deficiency, so most likely in type 1 diabetics, but sometimes can happen in type 2 as well. So, like I was saying, what happened is that this guy just stopped taking his insulin, and so his peripheral tissues aren't able to use glucose. And then, so when your muscles, your liver, types of tissues that are dependent upon insulin in order to get glucose don't get the insulin that they need, they go into what's considered starvation mode, and at that point they start producing other hormones in order to try to get energy. Okay, so the main hormone that gets, the main hormones that come out when these cells are in starvation mode are glucagon and then catecholamines. And so what this does is it sets up this negative feedback loop where glucagon is a hormone that, where you have this, so when glucagon gets produced, glucagon actually causes an increase in glucose levels in the blood. It also causes, you'll also get an increase in your catecholamines because these tissues are trying to break down and get energy however they can. So once you get a catecholamine release, that's going to cause fatty acid breakdown. Fatty acid breakdown leads to ketogenesis, which especially when you have glucagon in the system. So it creates this feedback loop where the peripheral tissues can't use the glucose that they have, so the glucose levels continue to go up. The glucagon is produced, epinephrine, other norepinephrine are produced. They cause fatty acid release, so lipolysis, and then those things together create ketogenesis. Okay? So any questions about that? All right. So, like I was saying down here, increase in glucose production in the liver and increase in breakdown of fatty acids equals kind of this this feedback loop where you continue to increase in the glucose levels as well as the development of keto acids. So what are the typical things you see in patients with diabetes? I mean, these are the DKA. So I wanted to give you a sense why we see those sort of things. So the nausea and vomiting comes from the high levels of the keto acids. They're just trigger kind of that nausea. Thirst and polyuria. So whenever you talk to somebody who has kind of undiagnosed diabetes or their sugars are really high, they're going to be peeing a ton. Right, so that's from an osmotic diuresis. Glucose is a very osmotically active substance, so they'll be peeing out tons and tons and tons of free water with their glucose. So they'll be spilling glucose, they'll be spilling potassium, they'll be spilling phos, but they'll be spilling a lot of free water too. And then the shortness of breath, so the acidosis, these are the patients that you see. So this is one of the things. When we see patients who are in DKA, they can be breathing really fast, really deep. Do we intubate them? And why don't we intubate them?
You're trying to get the gases out anyways.
They're doing it themselves, right? Typically patients with DKA are better than us at blowing off CO2 to maintain a reasonable pH. So that's why we typically don't intubate them. If they're very altered and they can't keep up anymore, that's when you may have to intubate somebody. Have you ever smelled the breath of somebody with DKA? So that's like acid. That's from acetone, which is one of the keto acids that's produced by the breakdown of these fatty acids. And then tachycardia is really from the dehydration, and then altered mental status is from the ketosis as well. So I don't know if you remember the Atkins diet a couple of years ago. They would talk about the high you could get from just eating protein and getting into this ketotic state. That's what they're talking about. So, but at high levels it creates this. So some of the typical lab values you're going to see, glucoses are 250 to 600. If you see them much higher than that, it's usually, let's say you didn't have any other lab values, and really high glucose levels are typically seen in patients more with like the hyperosmolar coma, but you can get them much higher. We have seen, I mean, I'm sure we've all seen patients with DKA who have glucose in the thousands as well, but these are some more typical values. Sodium, 125 to 135. So, sometimes we'll see a really low sodium and we're not really that concerned about it when patients with DKA. Do you know why? So, does anyone know, like, so sodium in DKA, so sodium is also an osmotic, it has an osmotic substance, but the other thing about sodium is that sodium gets diluted by when you have glucose at very high levels. Glucose, since it's osmotically active, it pulls free water into the plasma, so it dilutes your sodium out. So then we do this correction factor. We sometimes will be like, that's actually not the real sodium. The real sodium is going to be 140. So the correction factor is for every 100 above a glucose of 100. So if your glucose is 200, it's an extra 100. You add 1.6 to your sodium. That's a correction factor to say this is what your true sodium levels are once the glucose is corrected for. Okay, does that make sense? Because as you correct your sodium, or as you correct your glucose, the free water is going to go back away, and therefore then your true sodium levels are going to be revealed at that point. So that's why I use a correction of about 1.6 per 100 above 100 of the glucose. Potassium is normal to slightly high. One thing to know about DKA, people are generally potassium deficient. It's just that they're so contracted that the potassium levels seem higher than they really are. So we talk about replacing potassium very early on in patients with DKA because insulin will push potassium back into cells. And as you rehydrate, the deficit in potassium will become more apparent as well. So being aggressive about potassium replacement is really important in DKA. I know there's been questions about whether you hold the insulin drip in order to get potassium levels up. It's really just in DKA, the insulin is the most important part, but you got to manage your electrolytes. So if you find that your potassium levels are low, add it to your fluids that you're giving. That'll keep that way you're at least giving replacement while you're keeping the drip on. It's really not ideal to ever turn the drip off. Phos levels can be low, osmolarity is going to be high, and creatinine is going to be normal to slightly elevated. Your white blood cell counts are often elevated, and this is also secondary to contraction, as well as some there's inflammation associated with DKA. And then bicarbs is typically going to be less than 15. If you see someone in alcoholic ketoacidosis, it's not going to be that low generally. They can still have ketones in their blood, but they're not going to be that. Their bicarbs are not going to be that bad, and then you're going to have a very high anion gap. Okay? And so the three major pillars of treatment for DKA really are manage your glucose, manage fluids, and then manage electrolytes. So managing glucose, once again, this is the biggest thing. Starting with an insulin bolus, it's about 0.15 units per kg, or a 10-unit bolus, and then starting them on a drip. Okay? And then one of the things I think we always need to remember is don't turn off the drip until the gap is completely closed. And it's not about the sugars, it's really about the gap. That the keto acids and the acidosis in DKA are what trigger that feedback loop of the continuing to drive the ketosis, the lipolysis, all that. So you need to make sure that the gap is completely closed before you stop the insulin drip, or before you start the insulin. So, and it's very easy for patients who haven't received long-acting insulin or taken off the drip to jump right back into DKA and kind of go that cycle very quickly. Okay. So fluids, kind of our typical thing is just to give a bunch of NS up front. I think there are more nuanced ways to do this. If you correct for your sodium and patients' sodiums are high, you could start half normal much earlier than we typically do. But I think right now, because the main reason not to give a bunch of NS right off the bat is you can drive up their chloride and then you develop a hyperchloremic acidemia. But ideally you would do that, but I think based upon protocols, it's easier to just do the NS up to a certain point and then switch to the half NS with D5 at the point when blood glucoses are less than 250. And so one thing to remember is that there's a lot of fluid deficits in patients with DKA. They pee out so much fluid because their glucose is so high, so they're going to need lots of fluid. So hypotension should be treated with fluids, unless they have something like septic shock behind that caused it. Okay? And then managing electrolytes. So once again, replacing potassium prior to starting insulin if it's less than 3.5. And then giving supplemental potassium during insulin infusion as long as the potassium is less than 5.5 is what most places recommend. We don't do that necessarily. We do it as like kind of bolus. We got to give PRN potassium. We don't really put it in the fluids. A lot of places will just throw it in the fluids when you're replacing. And then also you might need phos and magnesium replacement as well. All right. And then the resolution of DKA is really, like I said, you have to continue the insulin drip until the anion gap is closed. And so that means the normal anion gap is usually less than 12. And so that's what we would say is when the anion gap is less than 12, you can transition over to sub-Q as well as, and then always remember to keep the drip on for at least an hour or two after giving sub-Q. All right, because it takes that long for the levels of insulin from your sub-Q insulin to build up to a point where you can actually, where they're going to protect against going back into DKA. All right, and then once the NI gap is closed, that signals a resolution of the ketoacid formation, and then you get the normal insulin to glucagon ratio. That's actually the biggest part of DKA. It's not the high glucose, it's the insulin to glucagon ratio that's causing this cycle. Okay? So this guy, the 22-year-old, you know, in the ED, he would have gotten a couple liters of fluid, get started on an insulin drip, got the insulin bolus, he'll come up to us, continue with, you know, we always continue with these aggressive fluids, and then, you know, let's say his sodium had gone up to once he's gotten his fluid, once we've given him a bunch of fluid back, he's not as contracted, his glucose is down, and his sodium's now up to 148. That's a good, you know, that's a time to realize we need to probably switch over to half normal at that point. So just something to think about. We don't always do that all the time, but correcting for the sodium and recognizing that if their sodium is really high, that they need free water as well, not just resuscitative fluid. They need initial resuscitative fluid, which is like NS, but they're also going to need free water at some point. Okay. Any questions? I know DK is not like the most fun topic. It's like, so key takeaways, DK patients will require aggressive fluid administration. Once again, continue the insulin drip until the anion gap is closed, and that they've received long-acting insulin, and make sure there's that overlap. And then replacing potassium aggressively is a really big part of this. So, and electrolyte management in general. So the major complications of DKA, especially in kids, are things like cerebral edema, and so managing electrolytes and make sure you don't have major osmotic shifts can be something you need to be very careful about. So more in kids than in adults. Okay. Yep.
Is it the same management if it's a DKA in a TBI patient?
In a TBI patient?
Yeah.
Yeah. Yeah. It shouldn't cause any it shouldn't be any different. You're talking about for their sodiums and stuff like that? Yeah, you don't, so in like a TBI, like a fresh TBI, well, you're still going to want to leave their sodium. You might want to dry them out a little bit more, but that would be a pretty complicated case. Because a TBI patient, if you want to keep their sodiums like above 145, you might not use your half normals, you would just let their sodiums drift up. That would be the only difference, really. But you can still correct, you still have to correct for their sodium, what their true sodium is based upon their glucose levels. So, because those are all osmotic. And so that's the whole thing. The whole goal of TBI management is to reduce the amount, is to really suck the, to reduce cerebral edema by kind of reducing the amount of free water there is around to kind of leak into the cells. So if you have osmotically active elements, that's why you use mannitol, right? Because mannitol does the same thing, it draws out free water, it causes the patient to pee it off. So as long as you correct it appropriately, you don't necessarily have to put, if someone was like at 135 but they had a really high glucose, they likely wouldn't need to be put on 3% if their corrected sodium was high. Does that make sense? Okay. Yep.
Dr. Shaw, you mentioned contracted, so you mentioned multiple times, what is that?
Oh, sorry, contracted just means they're volume depleted. So think of, they're hemoconcentrated, right? So that's why you'll sometimes see their white blood cell count be pretty high. Like I feel like we always see that, and then down in the ED they're going to start people on antibiotics because their white blood cell counts are high. But oftentimes that's just a matter of the fact that that's just because they're contracted or because they're volume depleted, so concentrated. Any other questions? No. All right. I guess the slides will be available.
Yeah, and the video.
Yeah.
Yeah.
All right. Have some donuts so that we can practice. Kevin.
You really don't regret it.
Yeah, but it's under-